Hi again. My name is Jim Rush, and if this is your first YouTube presentation with me, welcome, and thanks a lot for sharing some of your time with me. The reason I'm putting these presentations together is that I've had some wonderful people in my life that were very good to me and very patient with me along the road, and I wanted to kind of do a final thank you to them and leave something behind that maybe current and even future healthcare leaders can take a peek at and see if some of the things that I picked up along the way may be relevant to your experience. And if that's the case, then please use them in good health. The idea here was to put together a emergency management program that is cogent and is succinct enough that people will actually pay attention to it, And the emergency operation plan, I think most of us, certainly anybody who's in the leadership suite, has seen their share of voluminous emergency management plans that sit on a bookshelf and don't get looked at until the Joint Commission or another accrediting body is coming in. And there's a reason for that, and it's because they're so difficult to read. So I kind of suggested a different way of doing that. And that way is to first of all have a letter up front for all new employees that bears the signature of the Chief Executive Officer and outlines his or her commitment to emergency management and for staying available to the community both during and after any disaster. And then along with that, basically kind of a booklet that outlines this is the way we respond to all hazard events. And in that booklet, you would point to the various annexes. So when you get to materials management, you say, to get a better understanding of how supplies will be procured and distributed, go to Annex such and such materials management. And it makes it so much easier for people to read the overall brochure and then go to individual annexes when they require additional information. Just wanted to give leadership, and that's the C-suite folks, just a background on emergency management from the federal government standpoint. The Stafford Act was first written into law in November 1988. A lot of things have happened since that time, and the most recent update of that Stafford Act is the Disaster Recovery Reform Act of 2018. There's if you have any experience in the past with FEMA, you may recall their administrative policies, their 9500 series. I had a chance to go down to Galveston as the medical contractor for FEMA for Hurricane Ike recovery. And so I took a few things to heart when I was down there. It was a very difficult time for everybody involved in healthcare. There were more than a couple thousand people had to be laid off. So, and it wasn't clear what the future of healthcare on Galveston Island was going to look like. And so that's the last opportunity you ever have to have FEMA come in and start talking to you about what may or may not happen when you're in the throes of an existential threat. So I'll have a suggestion on that. But anyway, FEMA came out with the most recent guidelines, and your emergency manager should be conversant in it. And that's called the Public Assistance Program and Policy Guide 2020. And it's a large publication, so a lot of information there. And I'll have a suggestion toward the end of this that I think would be so helpful for healthcare. A member of the C-suite, I think most of you probably know that at least the Joint Commission looks to see whether or not there is involvement, not just buy-in, but true commitment and championship for an emergency management program. And again, it's an indication that you're determined that you're going to be here for your community and your patients, and you're going to have a place for your people, your employees, to work when this is all over. And it's worth the effort, and you're 100% on board with that. And that's what they want to see. And I'm pretty sure that the by and large, a large number of healthcare leaders have bought on to that a long time ago. But I think the one thing that's real clear too to any team coming in is whether or not you have a real culture of teamwork. Again, the C-suite at the top are completely committed, and then they have strong teaming relations between the emergency manager and the major sections that impact a hospital survival, which is plant operations, your physical plant, human resources, your staffing. How deep is your staffing? Do you just have that one full-time employee staff, or have you come up with arrangements where you can bring in the Medical Reserve Corps in your area, that you've worked together, you've exercised together, and they are part of your organization? You're going to have a lot better result if that's the case. And then again, materials manager, that's where your supplies, your equipment, contracts for medicinal gases, for contract services that are external, such as EMS, transport and other patient services, dialysis, any contract that between the hospital and other entity, even private practices would be reasonable to have a contract put in place that basically outlines all the particulars. The deeper your relationship is with your community and your healthcare providers in that community, I think the better things go for you. And the Emergency Management Committee, of course, I can see any number of ways where you would head up a committee like that, whether it's the chief nurse, the chief operating officer, or the chief executive officer, and potentially chief financial officer. But the most important part, though, is that you have a member of the C team heading up that community and making sure that the materials manager is getting the support they need from the various, and help between both ways, between the emergency manager and the directors and managers in your hospital, and also between the managers and the way they interact with the emergency manager helps an awful lot. Your executive committee will also provide oversight for your emergency management committee, and that's something that I was on a inspection team in Europe, and one of the things I look for is it's the executive committee providing real true oversight for the various committees in the hospital. And one way you know that they're not is if you keep seeing an open item for 2, 3, 4, 5 months. There's no oversight, and it points right back to the C-suite. Now, when FEMA comes to town, you want to make sure that you have as many things tied down as you possibly can when it comes to policies and procedures. And that's where your emergency manager can help you with that policy and program guide. It will outline what types of things, what facility management damages would be covered with public assistance, what supplies and equipment, services that will be covered for recovery, what staff resources, how about temporary employees, how about people from the community, professionals that you've credentialed and you've got contracts with them, are their services going to be covered by FEMA? And those things are outlined, I think, well in the program guide, but I have another suggestion on that. And also patient services, God forbid an evacuation, what's covered, EMS services, transport services, ambuses, etc., and patient medicines that go with, etc. And all those things are issues that will be resolved. I guess my only point here is that to the extent that you can get these matters resolved and understood fully and get prepared. One good example is equipment. You don't want to have to be trying to put together your hospital equipment list at the time that you know you've had phenomenal damage throughout the whole healthcare facility. That's not the time to try to piece together an equipment management list and then try to show where that equipment that was destroyed was in fact serviceable on the day it was destroyed. So there's a lot of little pieces here, but by getting them done ahead of time and having your program really tight, when FEMA comes to town, God forbid, a disaster befalls you, when they come to town, you've got the documentation right in front of you. And it will just make a horrible situation that much easier for you. Not a whole lot maybe, but better than if you didn't have those component parts together. And one of the things I'd recommend is the American Hospital Association and then the American Medical Association and the other professional associations need to point the way forward. After this pandemic, we need to talk about a unified healthcare, public health coverage for each community. So the idea that public health is over here and healthcare is over here, and there's no coordination anywhere in between, that really has to come to an end for the benefit of the people of the United States. And as far as so I think something has to come together at the top of not the government, but the top association leaders, and put together a program whereby a community's total health and medical program can be covered, rather than have two enterprises that don't talk to each other. From the FEMA side of the house, I'd like to see FEMA get rid of the idea of for-profit bad, non-profit good. That 1988, maybe times were different back then, but right now, to me, the most important aspect of a healthcare organization is whether or not it is essential for that community. If a for-profit gets no assistance from FEMA, if they have to close down, that whole community suffers because FEMA put a policy in place that said if you're a for-profit, you don't get public assistance. It should be based on the fact that this is a community asset. This truly is a part of the community's infrastructure. It's their health and medical infrastructure, and we have to do something to make sure that that infrastructure is secured now and in the future, and kind of lose our prejudices based on what is what's better or worse, or what's more altruistic, maybe is the word. But from now on, I'm hoping that we can get to a point where we look at the community's interest in the healthcare organization, and that above all else drives whether FEMA will or will not help to preserve that hospital and help it get back on its feet. Another thing, and I'll close with this, the American Hospital Association, the American Hospital Association really needs to request FEMA put together a conference that outlines for healthcare executives exactly what their package needs to be when they come to town. That would be so much better than to say, well, when you apply for a grant, and this is the day after or several days after your healthcare facility had taken a horrible hit with a disaster, maybe catastrophic hit, and then you're going to start? I don't think so. And I saw that back in Galveston, and I said to myself, I hope I can make a little bit of a difference there in planting the seed that FEMA needs to say to healthcare organizations and public health organizations, these are the things that you need to have. For instance, a medical equipment inventory list of every piece of medical equipment and non-medical equipment in your hospital, and what was in service that day, what was serviceable, what was not serviceable. You don't want them to try to pay for a piece of equipment that you were going to turn in or dispose of. That's all that is. But basically, what do you need from HR? You need the full-time equivalents. You need the temporary folks. You need independent healthcare individuals from the community. You need their hours. You need their overtime hours, etc. Those are the kind of things that a conference could end up providing a brochure that you could really turn into each of your action officers in your hospital and say, this is what your section looks like, and you need to put together the items that pertain to your department. And then get those all put together, and you have yourself a FEMA package that is worthy of public assistance. Again, thanks an awful lot for tuning in. If you want to see some of the other presentations I put up, just subscribe and hit the bell. I'm new to this, but that's what I'm told, so I'm going to put it out just that way. And I hope you do, and I hope that you find some of the things I discussed today to be helpful. Thank you.